So what I've tried to do is to think about where these valves fit into surgical practice. When you bring something new in, like TAVI came in, it was used in very high-risk population. What are we going to do with these? And my premise for this is that I think there are groups of patients who are very high risk for surgery, who do very badly with medical therapy, but if we can just get them through the operation, they then do very well. And I think that less invasive and sutureless techniques might actually help this group. So I'm just going to talk about a few things. We'll start with the UK data, look at stress echo, low flow AS, and then go on to the devices at the end. I'm sure all the registrars go to bed with this every night. There's an awful lot of data in it. But just to summarize the aortic valve data, there's been a huge increase in aortic valve replacement, and this is in a pre-TAVI era, the last iteration of the Blue Book. And the patients are becoming more elderly, higher risk, more comorbid, etc., etc. And yet, the operative mortality has dropped quite significantly. So what are these predictors of early and late mortality, and can we pick a winner? Well, obviously, we've got the standard Euroscore type features on the right-hand side with age, bad kidneys, peripheral vascular disease, etc. But one of the big things in it all is that if you have a bad ventricle, your mortality is dramatically higher. If you have bad symptoms, then your mortality is much higher indeed. And these groups tend to fare worse. This is NYHA class 3 and 4 versus 1 and 2, and this is the local population. But even so, we're still talking over 80% survival at 3 years in these highly symptomatic patients. Now, we define low-flow aortic stenosis as having high peak velocities, high mean pressures with a small valve area. When it comes to low-flow aortic stenosis, I think this is where the sort of groups we need to be looking at. We've still got the small orifice area, but what we've got is an impaired ventricle with a low ejection fraction, and we never get a high mean gradient. And what we're trying to work out is the low flow secondary to the aortic stenosis, or is it secondary to some other factors such as coronary artery disease or cardiomyopathy or what have you? This unfortunately won't play, but this is a wrecked ventricle with an ejection fraction of 15%. But this is not low flow aortic stenosis. This ventricle generates a Vmax of 6 meters a second. This is a ventricle that's dying to go, and it's come down this curve as you increase the afterload on it, and what you're hoping is that it will go back up that curve again once you relieve that load. With stress echo, what we're trying to do is to raise that mean gradient above 30, make sure that the orifice area doesn't increase, because if it does, you're not dealing with tight aortic stenosis, and also look for contractile reserve. We're looking at the velocity time integral across the outflow tract and looking for a significant rise. So what we usually see is a rising gradient, and here we now have 10 micrograms of dobutamine, and the gradient's gone up to 42. We've now demonstrated aortic stenosis, so I don't know why they went on to give 20, but what you tend to see is the more you thrash the ventricle, the more it falls away at the end. So we've defined tight aortic stenosis in this setting. We've shown with the velocity time integral has gone up from very low up to 17 centimeters with a big rise. This patient has tight aortic stenosis, and you can see that visually here. So how do we pick a winner from this group? Well, we can't, but we can predict the ones with poor outcome, and it's that group of patients where I think we should be looking. Here's a study from Europe, multi-center study from Europe, looking at tight aortic stenosis, poor ejection fractions, low gradients. Not everybody had contractile reserve, 25% without, but they're very highly symptomatic, and they've got a lot of heart failure. And overall, look at this, aortic valve replacement, 16% mortality. Those with the higher Euroscore did badly. Those with no contractile reserve did particularly badly. If you look at subgroups with multivessel coronary artery disease and poor LVs, they do the worst. And yet, in terms of the overall outcome, if you survived your operation, your ventricular function improved very dramatically. And symptomatically, we had 80% in NYHA 3-4 going down to 16%. So yes, it's a high-risk group, but the results of surgery lead to dramatic improvements in symptoms and outcome. Here we are again, similar, poor ejection fraction, mean of 29%, low gradients. Not everybody got treated with surgery, but these are patients who have no contractile reserve. These are the really worst ventricles that don't light up even when you thrash them. Again, highly symptomatic. High operative mortality, 22%, but even in this group, 5-year survival is still reasonable out at 70%. And what they found again is that the ejection fraction improves dramatically and the symptoms improve dramatically. And they came to various conclusions, but one of their conclusions was, is there a role for TAVI? Well, what can TAVI tell us? There's only one study that I know, and it's from Canada, looking at patients from across Canada who either had an AVR or a TAVI. They were all much the same in terms of their baseline, apart from the TAVI patients being older and more comorbid and with worse disease. TAVI mortality was very high, 19%, but it was equal when you matched them for age. In terms of overall ejection fraction improving, TAVI surgery improved things better than with open AVR. And we find that much more patients have very good ventricles with the lesser invasive approach. And we see that again in the very bad ventricles, that the TAVI results, the less invasive you can be, the better the outcome in terms of ventricular performance. And one of the features of this is that the TAVI device probably has a much larger valve area than the conventional bioprosthesis that we're putting in. And so if we can put in valves with better hemodynamics into this group of patients, I think they will do better. And not only that, but when you look at patients who've got no contractile reserve, that still does not predict the outcome after surgery. So this is a very worthwhile group of patients that we can treat. I think in the interest of time, let me move on, but I'll show again here that when you look at patients with and without contractile reserve, if you make it through surgery, you do very well. Operative mortality, very high. So I would say that the recovery is generally excellent, and the survival, if you get through your AVR, is very good, and the symptomatic improvements are dramatic. So, what will happen if we start using mini techniques and sutureless valves? Well, the two that are available that I know of are both now out on the market. There's the Intuity device, which is, if I said to you that there's a new BMW out and you'd never seen it, you'd sort of know what it would deliver. And that's the sort of background, I think, that I see in this device, is that it's built on an awful lot of years of background experience. And it blends the open approach with the TAVI approach, in that, having guided both the devices I'll show you down with 3 guiding sutures, this one can then be ballooned into place. It's not like TAVI where you just push the plunger. It's actually done up to particular pressure. And the other one is the Percival that you've heard mentioned already. Completely different design. This is much more like core valve, much taller device with an inlet, with an outlet, with wiggly sinusoidal struts to fill the valsalva sinuses, but also some strong struts to hold the device in place. But when you look at this again is going to have a much better hemodynamic profile than the standard valves that we use. They go in very differently. The last one that I showed you goes in by being ballooned into place a la TAVI. The Percival is collapsed down. They're careful to say it's not crimped, but it is tightened down in a sort of TAVI way to produce a smaller size, which can then spring into place once the device is released. So, my final conclusions are that AVR in a high-risk setting does carry an extremely high mortality. And yet, despite that, this is an extremely rewarding disease to treat because the people that come through do extremely well. I think that any surgical manoeuvres that we can bring in to reduce that mortality will mean that we can have a dramatic effect on this population, we can operate on a bigger cohort of patients, and we can do more good overall. That is where I see these valves starting out, but I strongly believe that in the fullness of time, people will say, do you know they once used to suture valves in? So I'd say use a combination of approach of mini-stenotomy with the new devices, and the population we can treat will be enlarged. Thank you very much.
Well, it's dawning on the nation, I think, that the NHS, which is the envy of the world, probably isn't the envy of the world, because we are struggling in an economically extremely difficult environment, and healthcare in the UK is a healthcare system that costs money rather than earns money, and within that scenario, our masters tend to think about things very differently. I was talking to a professor of cardiac surgery in Germany. The conversation was about LVADs, but we were talking about how you afford things. He said, well, my job is to treat patients, and it's the job of the hospital governors to work out how they fund my treatment of patients. Can you imagine taking that rationale back home? You know, we work in a completely different environment, but we can't stand still. So what are the drivers for surgical change and the use of this new technology? Well, the drivers are manifold. We've heard about some of them already this morning, but surgical need for me is possibly the greatest driver. Now, this case here on the top, you might as well, that's not a surgical case at all, that's a TAVI case, and that might be the case. But the one on the bottom doesn't project that well, but that's a porcelain aorta, and it's also a redo. So there are many cases like that actually as surgeons we end up operating on, we end up doing conventional surgery, but actually is that the right thing to do, and can we do better? The second driver is progress. If we don't try and push progress, then we'd still be using these devices here, which were fantastic for the time, but are probably not where we want to be to treat the patient range we need to treat in 2012. So we've got to go forward. And the third thing, of course, is patient expectations. Once patients know what is available for them, they'll want it, and quite rightly. Now, the drive for this in the UK is probably a lot slower than it is in countries like Germany or countries like America, but it's still there, and it should be there. I'll come on to that a bit later. We've seen in some of the preceding talks what's happening to cardiac surgery and aortic valve replacement in particular in the United Kingdom. And the patients are getting ever older. And this presents more challenges. It presents more technical challenges. It also presents more economic challenges. These patients have more morbidities, they stay in hospital longer, and have more healthcare costs associated with them. So if there's a technology out there that can reduce some of the morbidity, mortality, and healthcare costs, we need to be looking at this. This is some Southampton data, and as you can see, a good chunk of our patients really fall into the category where, no matter how good you are as surgeons, you will expect to have some associated morbidity and mortality simply because of the patients you're operating on. And if we can find some technology that helps us through some of those difficulties, we ought to be looking at them. One of the things that's been suggested is that things like sutureless aortic valves can save hospital costs and reduce patient morbidity and mortality by reducing clamp time and bypass time. I think this is probably not really the case. The majority of patients, this is again Southampton data, don't have exceptionally long cross-clamp or bypass times. And the patients to the far right of this picture probably reflect other difficulties. So I think this simple reduction in operating time is probably not the key thing to sutureless aortic valves. For me, these are the key things to sutureless aortic valves. This is a calcified root and a patient had a previous homograft. And no matter how good a surgeon you are, these are technically extremely challenging operations to do by conventional open surgery, excising the valve and suturing in a new valve. And even if you can do it perfectly, you still need a good chunk of luck to get the patient through this unscathed. So if there's a technology that can help make the most difficult part of this, the excising and suturing of the valve, easier, then it seems logical that we should be looking at it. This is another scenario that faces lots of us all the time now in increasing numbers. Previous coronary grafts, all grafts patent, particularly the mammary, and 10 or 15 years ago, if you look at these sort of patients, these mammaries are always going over the midline, and there's a significant morbidity, again, no matter how good you are, to operating on these patients. So if we've got something that facilitates us doing it through a smaller hole, in a less invasive way, being less destructive around the aorta, then that would be better for the patients, and we ought to be looking at it. One of the things about reducing operating time and reducing length of stay is that in a system that spends money rather than earns money, doing 2 aortic valve replacements with 2 10-day stays actually costs us nearly twice as much as it does to do 1 aortic valve replacement and have somebody stay in hospital for 20 days. Because we're paying the big upfront costs of prosthesis and ITU, and actually the costs of staying on the ward for mobilisation for 10 days are relatively small in our healthcare system. So we may not be saving costs here, but the cost we may not. But look at some of those things I showed you earlier. Actually, they're likely to stay in ITU a long time because we find the operation difficult. We have intraoperative complications, and they're the patients that stay in ITU a long time. And actually, if we can cut that down by using a simplified technique, well, then we may well be able to reduce overall costs. So it's a bit more than just overall hospital stay. I think that's the problem. If we look at the costs themselves against some of the other things that go along today in cardiac departments, aortic valve replacement, the prosthesis costs are now relatively low. TAVI, this is a ballpark figure, the prosthesis costs are relatively high. TAVI are a group of patients who, in the UK, we probably wouldn't be operating on. They would be on medical therapy and on the way to the afterlife. CRTD, cardiologists always seem to manage to get more out of the healthcare system than we do, probably because they've just done the thing before they've told anybody what it's cost. And if you look at the cost of occluding a left atrial appendage by a cardiologist, it's astronomical compared to what a surgeon can do it for. Sutureless AVR compared to these costs on the right, it's actually relatively cheap. And I think we all need to be marshalling our arguments to take to our local hospital boards to try and get this technology in. So how can we justify it? I think if we try and justify it down the minimal access route at this stage, we will have difficulty. Because minimal access surgery, we've seen some of the advantages, but I think they're relatively small. If we focus it on the group of patients that Chris talked about and some of the examples I've shown you, where actually it makes the surgery more doable and can dramatically change the comorbidity, the post-operative morbidity, mortality, and ITU length of stay, I think we're on much better ground. One of the advantages of having a nationalised health service is that we have the facility to take a nationalised view of this. And I think the work that was done over TAVI is a good example of how our professional bodies can get together and can bring strategies forward. Here we have a purely surgical technology, and I think the onus is perhaps on our society executive, and I suspect am I the only member in the room? I am. Is on our society executive to work with the Department of Health, the MRHA and NICE to make sure that these technologies become available across the country. Now, it may be that happens initially in a controlled trial fashion in some key centres, but we're not talking about enormous sums of money here to potentially facilitate some very difficult operations. And I think patients expect progress. And we need to utilise our patient supporters to make sure that the message gets across to those who fund healthcare here. And I think the final reason for doing the research output of the NHS, I think, does lag behind other healthcare services. And the Department of Health has made a big thing about improving research output. And it's by using these new devices in a controlled way that I think the NHS can contribute significantly to progress in healthcare. Thank you.
Steve, since you really did well on time, you do have time for a question.
No, there are no answers, I'm afraid.
And we can actually open it for about 4 minutes for a panel discussion about everything you've heard before we move to the industry session. Any burning questions to be asked? Or can I ask, Steve, it's a bit like Chris said, you're planning for your next BMW, but you don't know how to afford it. I mean, these patients, would you expect it to be a randomized trial, or could we look into a registry type thing with Ben sort of?
Well, I think, for example,
database?
the great and the good would say, where should we be using these devices? And I think initially you would go for proof of concept, so you do it in some relatively straightforward patients. I think for me, the meat of the study that enabled it would actually be in the difficult patients, to show that you can do a redo calcified homograph route with one of these, and get them through relatively unscathed. Whereas no matter how good you are, you're going to have problems with trying to do a conventional aortic valve replacement. So I'll probably then see it at the difficult end to show that actually there are some real advantages for the healthcare system, because we're going to operate on these patients anyway.
So the thing is, they're so few and far between that we wouldn't be able to randomize. I suspect it'll be a large registry eventually.
I think the registry route might be the only practical way forward. Yeah,
Chris.
Yeah, I totally agree. I think it'll be a registry. I do not think sutureless. I don't think sutureless should go head to head with TAVI.
No, I agree
I think
totally.
that would be the wrong course to go down. But I think it's sort of fitting in below the TAVI level. And if you think back to those of us that remember bubble oxygenators, membranes we couldn't afford, and so they were used in high-risk cases, and now bubble oxygenators are in the museum. Everybody uses them. And there will be that transition as we move. The costs will drop, and suddenly everybody, I think, will start to use this technology.
And we do need some help from industry. You will recover your costs in time, but you need to think again in an environment like the UK what the time frame is in which you're going to recover your costs. I know you're having these thoughts. I'm just airing them publicly.